Hi, welcome everyone. Welcome to the discussion we're going to have tonight. Really, it's on medical mistrust and skepticism. And really, this is a really timely discussion, especially what's been happening with, the vaccine rollout nationally, and also just in the general history of what it means to be Black and brown in this country. And so these are not new discussions. These are not discussions that are not well known to the people that are living them every day, but really, this is a chance and an opportunity to, get some medical providers together, also people that are embedded in communities where we work, and to just talk about them on a scale that, makes sense to the people that are listening. One of the things I think that I would just like to say is that, we are expecting questions. We don't know how many questions we're going to get, but we're expecting them. And if not, really, this should be kind of a popcorn conversation where we'll have a topic, not really a topic introduced. It's really just a bunch of us that have been doing this for a while, talking and just talking about our experiences, but then also talking about, themes of medical mistrust, what, and I want to be careful to not just be like, well, why does that happen? We all know why that happens. We're not here to inform the public about why we know things happen. We already know why, because we live in a society that is, white supremacist society, right?
Period.
So I'm not going to, period. So I'm not going to do that. Really, what we're going to talk about is just about like our experiences within the system, how we can, what has happened when we have tried to confront medical mistrust, or how we've even experienced it. And then also too about, what do we expect as medical professionals and people embedded in community? What do we expect our colleagues to do to combat this medical mistrust, acknowledge it, especially allies that are white? So kind of a confrontational discussion, but we're here for the things.
I love it.
Okay, so I would love to start with the loveliest Terri Reagan. Please introduce yourself, Terri. Then we'll go around.
Okay. Can everybody hear me? Hi, guys. I'm Terri Reagan. I am a physician assistant here in Rochester, New York with Shani. I work for Anthony Jordan Health Center, which is a federally qualified health center. I have been at my job for 15 years, working with the underserved community in Rochester, New York.
Thank you.
Bianca.
Hey everyone, my name is Bianca Castro. I am the Trans and GNC Care Coordinator for Trillium Health. I've been there about 1.5 years, but I've been working in the community since I was 15. Alongside, I'm also on the board for Rochester Black Pride.
Dr. Gard.
Hi, I'm Sabrina Gard. I am an assistant professor of medicine at Mount Sinai Hospital. I practice general primary care as well as HIV treatment and prevention there. Most recently, though, I've teamed up with 2 really good friends and sisters in health equity to form a nonprofit organization based out of New Jersey. We're just getting started. It's called Not Just a Black Body, which was originally an awareness campaign that was meant to bring important information about COVID-19 to those in historically marginalized populations. But over time, it's transformed into a movement that's calling for restorative justice in healthcare, particularly in the Black community. The aim is essentially to achieve this through community coalition building, education, and policy solutions. So I'm excited to be here and have this discussion.
Dr. South.
Hi, everyone. My name is Sire. I'm an assistant professor of medicine at Mount Sinai Internal Medicine Associates. I practice in 2 clinics, so a high-risk clinic within an interdisciplinary team for population individuals that are in and out of the hospitals due to a variety of reasons, but a lot of social issues, essentially. And then I'm also a provider in the REACH clinic, which is a substance use disorder / hepatitis C clinic. I'm a policy fellow currently with SGIM. And then Sabrina didn't mention because she's so humble, but Sabrina and I are working together along with a number of other people to look at how we could change the culture at our institution. It's definitely a work in progress. So we'll see kind of where that ends up, where those efforts go, but the will is there to try to do that work.
Thank you so much. And so what a great panel. So Shawnee Wilson, I'm also a physician assistant here in Rochester. I've been practicing for the last 8 years here in federally qualified health center spaces, just like Terri Reagan. I'm also, work alongside Bianca. We've worked together at Trillium back in the day, and then also worked with Rochester Black Pride, where I also serve as a core organizer. And, I wear a lot of hats here in the city, but one of the things that I'm really doing now is I'm chairing the Rochester Police Accountability Board, which is reimagining and redefining what public safety looks like. So, I'm hoping that, that is kind of the start of the discussion today. Really, we're looking at, a lot of the things that are happening, especially within our city around, what public safety should look like. And as far as like Black and brown people feeling safe. And, when we talk about our experiences of medical mistrust, I guess I just want to start with, how are you, and I just want to just have this be the start of the popcorning conversation. How are you addressing medical mistrust within your jobs, within your community? Like, how are you looking into it, addressing it?
I'll start. So, I mean, I think this is something that can be addressed in multiple different ways. Personally, I'm doing it in my own personal practice, but also, especially with the nonprofit that I'm a part of, not just the Black Body, we're doing it through community conversations. I think it's important first to understand what we're even talking about, right? When we say trust and also distrust and mistrust, I think there is a couple things going on. Number one, there's this misconception that that trust or mistrust and distrust is only affects certain populations. And, I think the way the conversation is kind of built around it oftentimes is that, the patient is responsible for, negative health outcomes that come from not trusting the system that they are, basically lending their bodies to get healthcare. So it's important when we talk about trust to understand that, our patients do have trust in us as providers because they are making themselves vulnerable to us when they come in for care to begin with, right? Like, so every time somebody comes in for an appointment, every time somebody presents their body to an emergency room, to a hospital, what have you, there is an element of trust that inherently has to exist for them to do that. But it lives simultaneously with distrust and mistrust. Mistrust is when you gave your trust to someone and that trust was violated in some way, shape, or form. And it doesn't necessarily have to be broken in terms of like, a large gesture or something that is huge and egregious that happens. It can be something as simple as, not doing what you say that you're going to do. I'll call you back and never call. I'll discuss this with you by the end of the visit and never have that discussion. We violate the trust of our patients all the time when they're making themselves vulnerable to us. And then I think that's a little bit different than distrust, or that's distrust. Mistrust kind of has to do with, especially a lot of the historical things, that we can, that all of us can kind of go into at some point, off the rip, to talk about all of the ways that trust within the medical institution, trust has been violated, and people really have been harmed, and especially through, oral traditions and us passing these stories down and knowing somebody who's gone through something. All of those things exist within, exist within the same person. So I have to know all of those things every time I'm in the presence of somebody who's already trusting me with their body in the individual encounter. And I have to acknowledge that harm has been done, and not assume that just because I have these letters behind my name, that somebody is automatically supposed to trust me to the nth degree and just do things as I say when I say it, because we would never expect that when we meet a stranger, off the street. So it starts with understanding what trust is, understanding that when people don't trust us as individuals and don't trust the institution that we work for, or just the health institution overall, that mistrust and distrust is completely valid. And we have to work to make ourselves trustworthy, so that relationship can even, begin to form.
Thank you so much. Any other comments?
I just want to second what Dr. Gard said. I mean, I think it's just a tremendous responsibility that we have as healthcare providers. It strikes me all the time just how many people put so much trust in me and the care that I'm doing. And it can sometimes be an overwhelming thing. But again, I think it's something that we have to be aware of and cognizant about, that, people, that trust is inherent in our relationship with our patients, and we got to take it seriously, right? So it is very much so. I just have to second a lot of what you said there, the responsibility that we have. And it starts by, we have to understand that and own it, right? I mean, we have to be very aware of the responsibility that we have as clinicians when we go in these rooms with the patient, that, this is, sometimes we're their everything at that time, right? They put so much trust in us. So I think what I take away from that is just understanding my personal responsibility to look inward and remember that, I have a part to play, a huge part to play in that trust. Sometimes the trust is automatically there just because of the reasons for the visit, but we can't take that lightly, right? Because it's fragile. It's very, very fragile.
And and I think that you highlight something that's super important, that trust, is fragile, right? Like, just because someone trusts us, with something, doesn't mean that they trust us with everything, right? Like, and that, certainly highlights itself when, we may know someone in the context of taking care of certain medical conditions, but when, but they may be, more protective over other parts of their, humanity, right? Including, their sexual well-being. That is not something that's automatically given just because we talk about other things all the time. And we should never assume that we have the patient's trust to begin with. And we're constantly needing to work to cultivate a relationship where we're actually demonstrating ourselves to be trustworthy. And a patient can trust us as an individual provider and still not trust the rest of the institution, right? Like, so they may feel a certain way when they're in an office with me, but that doesn't mean that they have the same level of trust to my staff, or, to the administration. They may not trust the hospital system. And just because they trust me doesn't necessarily mean that they are going, that they're putty in my hands, nor should it ever be. I think we're reaching a point now in healthcare, especially with the way that COVID-19 has kind of really exposed and laid bare a lot of the racism that exists within the fabric of the institution of healthcare. We're really, like, every instance that we engage with our patients, whether it's on the telephone, whether it's in person, is an opportunity to build trust, but also an opportunity for that trust to break down. And we have to take that seriously.
Along those lines, and kind of what's been mentioned, that patient-provider relationship does not happen in a vacuum, right? That patient is coming with a world of experiences from, in the past, time and space-wise, where they've been to other hospitals, been to other clinics, other emergency rooms, other providers, and carry those experiences with them. The majority of the patients I see in both of the clinics I work in come in with a deep distrust of the system. And I always take it as it's part of my job to essentially rebuild some of that trust. And sometimes you can, with a meaning trust of the system, sometimes you cannot. And it's just maybe you work on just that individual relationship where they could trust you, as Sabrina said, but they won't trust the system. And so I think oftentimes within healthcare, that point is missed. Healthcare, I think, hasn't done the job of looking at its history and how it has contributed to distrust for several communities, right? I think the equivalent is a firefighter burning down your house and then coming down later with the hose to save the house, or what's remaining of it, right? When you look at the trials that have happened in the healthcare system, whether it's vaccinations, whether it's essentially torture of various populations, and then now kind of a surprise is, well, these populations are not accepting the vaccine that's out there, despite the fact that they're more heavily affected by COVID. Well, there's a reason for that. None of this is happening within a vacuum. I think historically, there have been a lot of factors at play here. And even currently, you look at segregation of care, you look at all these other things that contribute to distrust, both at the community level and at the individual level. People carry that, they carry those scars. Even if they haven't experienced it themselves, they know someone who has. And within the generation before, or even in the current generation, or they have themselves. And everything that we do that kind of repeats, I think this trauma only adds them to the distrust. So oftentimes I've heard patients say that within the first few seconds of meeting you, they kind of have made up their mind on you. They kind of know. And that matters. And I think as a healthcare system, you haven't done a good enough job of thinking about it, of having the discussions about it, and then of course being able to address it.
Correct. Bianca, did you want to say something too?
So in my practice, when patients come in to see me, I'm usually the first brown face they see. So they automatically look to me as someone, oh, should I trust her? And that puts a lot of weight on me, because not only am I a Black woman, I'm taking your health in my hands. So now we're both wondering who we can trust. And I just make it my duty to stay educated. And if I don't know something, I make sure I get them connected to the proper person, whether it's Shawnee or messaging Shawnee to make sure that I'm saying the right things, or making sure that they're connected to people that actually care about them, that don't look to them as a number, or we just need numbers for testing, so I'm going to push you getting on PrEP, or just making sure that I build that trust, like Dr. Sal said, making sure I build that trust with them, because I am one of the only women of color, and then being a trans woman on top of that, they look to me as, okay, she knows I'm going to keep it real with you, and I'm going to meet you at your level and make sure that the health literacy is there and that we both get what we need from this. So.
One of the things that occurred to me as you all were talking was about, my own, our own things that we carry into the visit with us, right? That our own ideas of medical mistrust, the experiences of people that we know, and the experiences of, knowing how the system works. Let's be honest here. We know that we have a person that has, colon cancer, stage 3 or something like that. We just found it. And, we know that their course is not going to be easy. We know that if a person with mental illness has no insurance, that they are not going to have an easy course, right? So all of that too is I wouldn't say, I guess just knowing, being jaded by the system as well is kind of the burnout that we all face, right? And just, knowing that, we all carry our own ideas and our own family's experiences within the system that the system has not worked for them. So it really is hard to carry all of that with you when you are, seeing people on a day-to-day basis, knowing that, there are only 2% of the population of PAs that are Black and brown, right? That we are so vastly underrepresented in a lot of the fields that we're in, that it's carrying the weight of the world on your shoulders. It's real. And, I think one of the things that as Terri was talking, I had a patient that waited a year to tell me that she had been sexually assaulted, by an officer. And so I had to, deal with that. But I was just I was so relieved as she told me, but all of a sudden, all of her symptoms made sense to me. Right. But how long did that take? And I just felt terrible because she was, former sex worker that just learned learned helplessness, right? That your experiences, you don't matter. And so that's another thing that we're having to deal with when we're talking to patients every day. So.
Yeah, and it's absolutely traumatic, right? We know how traumatic it is for the patient to come to us, be vulnerable, but still have to deal with the weight of all of the stigma of every ism, right? Like, and, you know, the more, you know, especially when we're talking about, you know, intersectionality, the more, you know, you have to, you know, if you're a woman of color, you know, especially a Black woman, if you are, you know, especially trans Black women, like there is this weight, this enormous weight of an experience of example after example of the world telling them that, you know, what they have to say is not valuable, what their experiences are, you know, does not matter, you know, and you know, they just have to deal, you know, go it alone, you know, for the most part. And this is what we as healthcare providers, when we have folks in front of us, like this is like, it's like moving a boulder up a mountain, right? So there's already that on the shoulders of the patient. And then there is the weight of us as providers understanding, right, the additional hurdles that every person is unique, but knowing the additional hurdles that, you know, they're going to have to face because of the way the system is structured. It's traumatic, you know, all around. So we're all kind of trying to navigate, you know, we're trying to navigate this together at the same time, you know, wanting folks to trust us. Like, to me, it's like, it's mind boggling. I don't know, like those things don't compute generally to me. You know, and I'm very much a part of the system. I know how the system works. So I can only, it's not often that I'm on the other side, because I too harbor lots of mistrust in our medical system, so much so that I try to access it as little as possible because I already know.
So like, you already know how it's going to go. Like that's the thing.
So yeah, it's absolutely crazy. But yeah, I want to hold space for, you know, the others on the panel to comment on that as well.
Yeah, it's kind of the blessing and the curse of working in the system. You know how the system works, you know, so, and we know it intimately, right? We know it from the inside. So that is sometimes the levels of trauma that I experience on my day, just the mental trauma, you know, trying to deal with all of that, plus dealing with my patients who are going through some tremendous issues, right? And trying to deal with that in a system that has historically been
Trash.
Just not the best, right? We'll just say that. Yeah, you know, it's a lot. It can be quite a bit, day to day.
Well, I think the thing too is that our patients are casualties, right? And I hate to be kind of sad about it, but we're looking at COVID right now with a great example. I've had people tell me that they would rather die than take the vaccine. Like, that's real, y'all. Like, that's real. You know, they would rather die than take a vaccine that they don't know. And, you know, then we have a culture of medical culture, which is, and also Black culture too, honestly, that is like, well, you better take this vaccine, you know, and they'll wag their fingers and they'll just be like, you know, you better do this. And then the other medical community is like, oh, why won't they just take it? You know, because, you know, obviously, I mean, they're like, you peel that back and it's frustration, it's fear, it's anger, it's like, you know, annoyance, but, you know, and that's coming from everybody. It's coming from us too. You know, we still are like, you know, we really don't want you to die, but then it's like, but then, you know, we have trouble in a lot of these spaces holding space for those that just have such a deep history of mistrust, not from like, you know, Tuskegee and not from Henrietta Lacks. Like, we're not even talking about that. We're talking about now. We're talking about today. We're talking about the role of, you know, criminalization and medicine, the role that medicine has played and providers have played in, you know, putting away people into custody, taking them out of custody, HIV criminalization, you know, so those are the things that I want medical providers, people in the system to understand. It's like, I don't have to go back, you know, 60 years. I just have to go back 3. I have to go back 10. So I guess that, you know, to the panel, I asked a question, you know, how is it that, how do you feel that, you know, you talked about building allyship with our patients, right? Because ultimately we are really the ones in authority over them in that system. But I'm just wondering how you think, like, you know, patient allyship like if you are an ally, like how would that true ally, what does that look like to you all?
I think I would say one of the, we talked about criminalization. Addiction medicine is like one of the key things there, right? You look at society's response to addiction largely has been to blame, judge, punish, criminalize. And so the relationship that people who suffer from addiction have had with people in authority, in positions of authority, has been one based on fear, one based on suspicion, and one in which they've learned that their lives don't matter, right? And so I think one of the, as a provider, one of the main interventions, honestly, you could do is actually listen to the patient and essentially kind of rebuild that notion that their lives actually do matter. That actually goes further, I think, than any other intervention. That's the start. Because if you don't even establish that, forget any medications you're trying to prescribe. And I think that can be generalized to other populations as well. Marginalized populations and communities that come from this world where they are constantly told day in and day out that their lives don't matter. Sometimes it can be in overt ways, and that's what you see in the police violence. Sometimes you can see that in much more subtle ways, through TV, through media, through other things, through other channels, where they're constantly told that they don't matter. So I think allyship, starts with kind of negating that that notion and rebuilding that from the ground up, that you actually do matter. And you're the expert of your body. I may know medicine, but you're the expert of your body. So you're essentially going to guide this with my help along. And I think, again, within the first seconds, patients kind of have their mind made up on you, right? Within the first seconds of meeting you, depending on how you come across, they may have already an idea of how they feel. I had a patient who suffers from cocaine addiction. Within our first when we started the meeting, we started our first visit, the first thing she asked me before we even got started was, what are your thoughts on addiction? Like what? And she was just really trying to get to my mind in terms of, do you have any sort of bias towards people like me? Do you have any sort of judgment? And so
that's amazing.
And so we had a great rapport moving forward, but that set the tone for the rest, I think, of the visits. And I think that's true of any field, not just health. Anytime you've had exploitation, anytime you've had dehumanization, which we've had, I think, in healthcare, you're going to have to rebuild trust. There was a New York Times article just today on education and the fact that Black and brown families, parents, do not want their children going back to school, despite the fact that they're more affected by remote learning and negative outcomes of that. But there's no trust in that system because the education system, same thing as the healthcare system, same thing as you name every other system in our society, right? And unless you go back to the root cause of all of that and actually address that and have conversations about that, you're going to have these issues, unfortunately, I think.
Absolutely. And to go back to the question in terms of like allyship, the term is always one that kind of, sends a chill down my spine. Like, cause I think it's like, I feel like it's not, there's nothing that someone can do, right, that will, give them this stamp of allyship, and then they don't have to do anything else, right? I think a lot of the times when folks talk about being an ally and allyship, it's like some level that you have to reach, and once you've reached that level, like, okay, I'm woke now, like, that's it, like I've done what I have to do, and nothing could be further from the truth, right? If you're talking about allyship, I think that the way to speak about it is the fact that it is it's an active process. It's a verb. It's like something that you have to actively engage in all of the time. It should never be a label that anybody gives themselves, that's for sure. And I don't think that anybody should be aspiring to be an ally. I think people can do things that are acts of allyship. So I mean, regarding trust, and I think the same thing about trust, right? I feel like trust and trust building is something that's a very active process, right? You don't just, somebody comes in, they judge you based, off of the first few minutes of the encounter. whatever conclusion they come to, that doesn't necessarily, whether it's trust, I trust this person right now or I don't, doesn't mean that it's going to be the same level throughout the entire encounter. It doesn't mean that it's going to be at the same, at the same level throughout the lifetime of the relationship. It's something that's very active. I think one thing that we need to do in order to build trust, in order, as an act of allyship, is be honest and tell the truth, right? And tell the unvarnished truth. There's a lot. Bianca said something earlier when she is talking about, how she's interacting with a patient, and, there may be something that she doesn't know in that moment, but, can say, you know what? I don't know the answer right now, but I can connect you to somebody that does. Or I don't know the answer right now. I have to do some research and get back to you. That seemingly very small act of being honest and telling the truth about your own limitations personally is something that can go a long way when it comes to trust building with someone, and letting them know that that you have limitations, and you would love for them to extend grace to you, and they may have limitations, and we will always extend grace to them, especially in this very active, this very active relationship that we'll be having for maybe it's months, maybe it's years, but this is something that's kind of constantly moving. So ally, or being an ally is not a thing, but acts of allyship, is probably better in terms of how we describe it. It's an active process, and honesty in all forms, at all levels, is going to be important if we have any hope of making progress in either one of those things.
Yeah, I agree. I think, I think we all learn in this school, first do no harm, right? And sometimes, sometimes that harm can be unintentional. And I think to your point is that knowing what your limits are and being honest about that. Listen, I get those questions all the time. I'm in family medicine. So, we do a little bit of everything, but we do a little bit of everything, right? Mm-hmm. So I'm no subject matter expert in one thing. So like that patient who would ask, well, how do you feel about addiction? And you're just like, what? Okay. Answering that question though, can set the bar, right? Yeah, that can really make or break it. And I think the idea is, again, you may not even have an answer to that question right away. And it's okay to admit that. Like, you know what I mean? I think you're absolutely right. Just being so transparent about where you're at, if you don't know something, admit it. And just first things first, do your level best to just don't harm the patient as much as humanly possible, right?
And to kind of piggy off of what Sabrina said, what I've noticed is a lot of these agencies, especially during the Black Lives Matter riots, they thought just putting up a sign that says Black Lives Matter meant they were an ally, or handing out T-shirts, being very performative, but never really acknowledging their role in perpetuating mistrust. And it was very gimmicky, very, I'm going to just put Black Lives Matter on a T-shirt that says my agency's name and I'm an ally.
Oh my gosh.
When the real goal should be to in partnership with Black Lives Matter creators, or protesters and leaders, should be an allyship in creating forums so that we can discuss why we don't trust you or why we feel this way, and giving them opportunity to answer those questions and not be judgmental, and really just be real with them, and not just say I'm an ally because I put BLM all over my agency, but never really did anything.
That's absolutely true. And I think part of that, of being honest, right, and telling the truth about ways is going to involve actually looking in a mirror and being uncomfortable. I think so many times, and it's so many different instances, we get to the point where maybe we start having the conversation, but as soon as it gets a little bit uncomfortable, folks want to retreat and not touch the subject anymore. And the only way that we're going to be able to make it through is being comfortable with being uncomfortable, and really push forward this need to be honest and to understand how we have contributed to harm, right? And not just at the individual level. We're all talking about ways that we can, build trust and acts of allyship that we can have with our patients when they're in the office with us. But we're part of these large organizations that have historically participated and continue to participate in harm done to our communities to this day. Right? Like as in right now, I'm talking about research that's being conducted where they're using race as a biologic construct as if it's not 2021 and we don't know that race is not a biological construct, but a social one, right? Institutions need to be honest with the fact that they've been contributing. And unless they're honest with that and folks are looking at you, they're watching you to see what you do. And if you can really peel back the layers of your participation in this system and participation in their historical harm and current harm to see if you are worth trusting, because I personally am not going to trust someone who consistently shows me that they're not trustworthy, right? So I can't have this conversation and place blame on folks that said, listen, I would rather die than take this vaccine. What they're saying is, they're not saying that they would rather, that they want to be dead. They're saying that I think that what you could potentially do to me is worse than what this virus can do to me. Mm-hmm. And that's because they have the stories to prove that this institution has done harm. This is not unreasonable, right? They're reasonably skeptical. Right. And what they're saying is, I don't trust you. I don't trust that there is something higher at play. Maybe you don't know about it, Doc, as I'm sitting in your office and I love you and I trust you. But your boss or whoever you work for, or the government, the pharmaceutical companies, I don't trust them. And I am not willing to put my life on the line, to be a check in the box of, yes, this person is vaccinated. And that's real. And that is what we need to be trying to understand, like, the level of skepticism that really pervades our communities, because it's happened before.
So one of the things I think of, in the discussion of allyship, I did a talk, I think almost 2 weeks ago now, on just with a bunch of medical professionals, like mental health folks. And, they talked about, one person talked about the concept of allyship, what I really thought was interesting. And I will kind of share this with you. So talked about like World War I, the Allied powers versus the Axis powers, right? Where you had, you had Great Britain, you had the United States, Russia, and you had, I think, France. I think that's made the Allied powers, but they all came to one common goal, and they all had they were there for, the goal to stop, I think Germany from, taking over. And I know my history is not great, but we know why. Obviously they were ganging up on Germany to make sure that Germany didn't take over Europe. But then when they had that one common goal, what did they do? They formed a partnership, and they came up with some of the things that we see today. And I think NATO. I don't know. That's embarrassing. But anyway. Somebody could correct me in the chat. But either way, long-term partnerships that have still going on today. But I think one of the things is to kind of tie these things together, it's like somebody's already reading me in the chat.
World War II.
Was it World War I or World War II? Oh, well, they'll get me. But one of the things is too, folks, is like, if you are not at a point with your partnership, allyship, whatever that ship is, where you see a burning building, to get back to Dr. Sal's analogy, and you're not trying to run in to save everybody you can, then you don't understand what allyship is or what this is. Because we are dealing with an emergency here of, this is an emergency. This is a 911 emergency. And we have people that need help. And instead we have, just to Bianca's point, we have organizations that would rather stand outside with a clipboard, tell us what's going on, put up a, let's make a, what I deal with all the time in government, commission or something else on something.
A task force.
Task force. Let's hire a diversity person. That's probably Black. And then, then we're gonna fix everything. But really it only turns out being one thing, which is probably a t-shirt.
And something that's very comfortable, correct. Right? They don't actually want you to be effective, right? They just want you to do something that gives the image of
that
you're doing something. Black
right.
Lives Matter.
Well,
performative.
They do. So yeah, I think that like, I think after a lot of this stuff, especially stuff over the summer, like it just radicalized me, I believe, and just being like, you know what, we have a duty to hold these people accountable, place accountable, because, like, we talk about medical mistrust. We can't, as Black and brown people, step out of that. It is like, and privilege is what? We talk about white privilege or just being privileged in medicine, which is, you have access to things that other people don't have, right? You have, white privilege is saying, like, for instance, that you can have, that you have a choice to be discriminated against, or you have a choice not to be. It is something that you can move in and out of, right? Like, you can leave this burning building whenever you want. There's other people that are just stuck inside behind locked doors that can't get out. That's the issue. And so, when I point out privilege to folks and talk about the origins of medical mistrust, it's apathy, but then it's also privilege, that you can just leave whenever you want to leave. You can just go. But there are other people that are dying inside, trying to bang to get out of this building. And we have people that are standing outside with a clipboard and just wondering, well, how do we make this, like, give us an advantage in the community and then also help us make more money? But really, we're just trying to be out here saving people's lives. So soapbox over.
Along those lines, you can call me Sire, by the way. Everyone on the panel. Along those lines, in terms of what's been said, you look at, we're essentially discussing anti-racism, right? That's kind of what we're talking about. We're talking about doing the work. Are organizations doing the work, or is it just a Black Lives Matter shirt and everything is okay? It comes down to two things. I felt one is, to me, you can never take away someone's humanity without losing your own. Right? Like, whether it's slavery, whether it's racism, any sort of exploitation, I think you lose some part of humanity, of your own humanity, when you do that to someone else. That's the number one thing that we need to recognize. So what does that mean? That means that racism doesn't just affect Black and brown people, it affects our entire society, right? And there are repercussions at every level. And so you can't achieve overall safety until you make sure that everyone is taking part in this. It's not just an issue for Black and brown people or marginalized populations in general. And I think the second part of it is, for myself, speaking for myself, as a Black male, I've had to confront racism. I didn't have a choice, I don't have a choice to run away from it or anything like that. I've had to make my own kind of education and growth towards it. So I grew up moving around, and one of the things I remember, we lived in France, and I was, I think, 10 or 11 years old. The first time I ever saw Black representation, because I never saw it on TV. I saw it on a billboard as, like, my dad was driving. And I remember just telling him, I didn't know Black people could be on billboards. Like, that just blew my mind. That just blew my mind as a kid. And that was one of the things that made him decide, we're gonna leave this country. And France has a deep history also of racism, segregation. But essentially, he decided, well, let's move and let's go to another. US seems like a country that maybe has it ish together, right? little did he know.
Well.
All of that is to say that I didn't have a choice but then to confront that growing up. That as a Black person, I am someone. As a Black person, I can achieve something. I can be on that billboard, or I can do something else, right? I've had to confront that and make that growth. And I think what we have in a society is we have a certain group of people facing racism and another group of people that maybe have the privilege to not face it and can afford to not see it because it's out of sight, sometimes therefore out of mind. And so it's in another community way over there that does not affect me. It's on the other side of the tracks. And then you look at the institutions and the leaders. Who are those leaders? Are those leaders, is that a diverse leadership, and does that represent all of society, so that you have actually well-informed decisions and policies, as opposed to, is it just a group of people who actually maybe have not faced racism or any sort of ism, and have not had to have that growth? And I think that's when you have institutions kind of have just the gimmicks of, I partner, I'm an ally, without actually really doing any of the work that goes with that. Institutions are people. It's people that are making those decisions. There are people in each of those institutions making those decisions. And who are those people? That's where the conversation starts to me, I think.
I can't say that any better myself, but I will continue on that point in the sense that it's important, when we're talking about trust building, when we're talking about active allyship, what's I think the central role in that is really recognizing, right, the humanity of the population that we're taking care of the person that's sitting in front of us. And it's hard to do that when you're not in community and you're not invested if you're not in community with your patients, if you're not in community with the community within which you're practicing, right? It's like you don't have you don't have any skin in the game, right? If you don't recognize the full humanity of the person in front of you. I think part of for medical training, for example, often incentivizes dehumanizing these folks, right? Like with the time crunch that you have to see patients where things have to be done in a certain time frame, where it's all about, how many, what proportion of the patients that are in your list can you get the flu vaccine for, or, take care of their blood pressure, so on and so forth. It's like people are reduced to, statistics and metrics. And that is not how that's not how you build a relationship with anyone. I tell my patients, especially when we first meet, this is like when you're looking for a provider, and I'll tell my family also, when you're looking for a provider, it's kind of like going on a date. Like, is this somebody that you really want? If you meet a provider and you don't like them because there's something about the vibe that's off, literally anything. It doesn't, like, you don't have to be with this person, right? Like, you can decide that you can pick yourself up and maybe, opt for a different person, because there needs to be this human connection, right? It's important to me to know when, if your spouse passed away, or maybe, you just got a new dog or something like that. I would want to know that if you were my sister, if you were my aunt, if you were my grandmother, if you were my mother. And that is the type of relationship that I try to cultivate with every single person that's sitting in front of me. They're a human being first. Before we get to any word that I write down in the chart, before I offer you any vaccine or offer you any blood test, I need to know who you are as a human. And, when it comes to the care that we provide, part of trust building is collaboration. Sire said, the patient, in the driver's seat or in the passenger seat, like next to you, and but the patient is the most experienced person in them. Like, they are the ones that know themselves best, and I can provide maybe some medical expertise, but because I'm in community with you and I want to understand what your goals are, I can tell you some things that I know from my training that I can help you achieve your goal. Whether that goal is, I don't want the flu this year, I'm not trying to be sick in the hospital with COVID, I don't want a stroke, or I want to, I'm not having a trouble ejaculating, whatever it is, right? Like, these are the things that, these very human conversations that we're having with folks. And I think the way that the system is structured, perhaps is not necessarily conducive to providers actually just being in community with the folks that we're taking care of. And that is negatively impacting our ability to really have trusting relationships with our patients.
Yeah, and I think that's the balance, right? Because I think, as you were talking, I thought about it, the amount of time that I have in my day for my appointments is not congruent with what I'm had with the person sitting in front of me. Like, I need more time than this 20 minutes is going to allow me, right? Right. It's just, correct. So, that is the part of the system that becomes frustrating and limits us in our ability. I think even with that, though, no excuses. We still have to remember humanity. Humanity has to come first. Shani talked about it a little bit earlier, but we're going through in Rochester right now with what's going on in our community. The biggest thing that I see in all of that was for a 9-year-old girl who just got pepper sprayed. Where was the humanity?
Can you imagine?
And I think we as clinicians, we need to keep that always, always in not in the back of our minds. It needs to be in the forefront. If we're going to talk about breaking down these systems and building trust, and like you said, we're also clinicians of color, so we not only deal with racism, with our patients, but we've dealt with it personally, right? We just have to be it has to stay in the forefront of our mind that this, regardless of what else is going on, this is a human being sitting in front of me.
At the end of the day, right? Because you have to, you need to, right? You have to dehumanize in order to harm, right? Sire talked about it when we're talking about like even back during the transatlantic slave trade. You don't do that to people that you believe are human like you're human, right? So you need to dehumanize in order for harm to be done. If we want to, fast forward to 2021 and how that manifests during a clinic encounter, you have to dehumanize somebody to ignore their phone call. You have to dehumanize someone to rush them through a visit when they are crying, and they're telling you that they're in pain. You have to dehumanize them to, to not continue a conversation, even though you have two people waiting, right? There's almost, it's almost like something that you need to do in your own mind in order to say like, okay, let me just cut off this emotion piece and this person has to go because I have other things that are going on. And one of the things that I don't know if you guys know this Scott, her name is Brene Brown, but she does this wonderful she's written this wonderful thing up on trust and like what the anatomy of trust is. And she has this acronym called is it Braves? No, it's called Braving, BRAVINGE. But one of them is integrity, right? And, you can't have trust without integrity. And integrity, what integrity looks like is choosing courage over comfort, choosing what's right over what's fast, what's fun, what's easy, practicing your values, not just professing them. And I think if we talk about that being a core feature in, a trusting relationship, if people are truly honest with themselves, how many times did you choose to do something that's easy instead of what you really thought that the patient needed? Because if you can recognize when you're doing it, when you're doing something that is, the antithesis of trust building, then maybe, right, you can actually, do what it takes to really build on trust and to call out when other folks around you are doing things that are the opposite of building trust with not just a person, but with an entire community that you're there to serve. To really look in the mirror and say, like, what am I doing that is the opposite of what I should be doing if I want to really be seen as a trustworthy person, a trustworthy practice, a trustworthy institution. If you're not telling the truth, then there's no way forward.
Yep. So we have our first question, folks. I'm going to go ahead and read it. So a person is asking, with a patient, how do you balance health science in medicine with a patient's mistrust, which may ultimately harm Black or brown folks? Anybody else? Anybody can feel free to answer.
One of the things for me, and I'm just going to talk about it in the setting of the initial visit, but I think Sabrina already touched on this perfectly, is to go beyond the medicine and to actually look at the person in front of you as a human being. So I make it a point generally that any new patient visit I do, and I'm lucky that I get more time, I think, than the general provider for that. I don't dive into the medical part at all. I will start and spend 50% of that visit only on the social history. Why? Because that, as opposed to them starting off and me talking about, okay, you have diabetes and you have CHF and so on. The first question is, where were you born? Where were you raised? When did you, if you're not from New York, when did you come to New York? Who are your parents? Who's your social support? And I think it tells you so much about the person. It gives you an opportunity to explore any sort of past traumatic experiences with the healthcare system. and maybe then be able to, that keeps that in the back of your mind. It tells you about their belief system. It tells you about their social support network. So it tells you so much more, I think, than the medications and so on. So typically, there are times when I go so much on the other end that I spend an hour and we didn't talk about so much to medicine. But typically, I've looked at the chart beforehand, so I have an idea. I know what problems are there. And I'll try to address it still. Typically, I'll spend 15, 20 minutes addressing that at the end of the visit. Sometimes I haven't been able to, but I know I'll bring you back. And I know that it's okay. I'll bring you back next time. And if instead I've used that first initial visit for trust building, for rapport building, so that I see you as a human being, you get to know me as a human being, and that lays kind of the groundwork. But as I think also has been said before, that's dynamic. That doesn't stay static. You have to continue to work on that. And so I think that's one of the first things, I think, for me, is getting to know the person as an individual and what brings them here, as opposed to not the medical part, but the social part.
I agree wholeheartedly. I don't have as much time in my practice as you do, Sire, but I certainly make it a point to really understand, to really just have a conversation, like a regular conversation. Most of the time, like the patients are a little bit freaked out, I have to say. And I think that really speaks to like them not having an experience like this in the healthcare system before. And to me, that's more sad than it is like, oh, you know, I'm not patting myself on the back for that. I'm saying, oh my gosh, we have a lot of work to do, because when I treat you like I would treat literally like my grandmother or my mom, you know, you're like, oh my gosh, I've never been treated. Like, have you ever been in like a traumatic relationship, right? Like a really traumatic relationship, and then you leave it somehow, and then the next relationship you're in, it's with somebody that's like much better, and you're just like, I don't know what's going on. Like, that's
not real?
Right? Are you real? Like, are you going to go away? Like, just tell me, and I literally hear this question all the time. Like, how long are you going to be here? Like, you're going to leave, aren't you? Like, just tell me like when you're going to abandon me, because, you know, and that's really, it really does speak to the fact that people are truly craving. And especially, as Siri mentioned before, particularly if they happen to constantly be bombarded with example after example of what seems of reinforcement of this idea that they don't matter, right? For someone to really say like, no, like let's talk about you, and only you, you know, to some degree for once. Yes, tell me about the people in your life and how, you know, they're there to support you or not supporting you, but really just having that human connection with anyone and everyone that you come into contact with in, you know, like that comes across your office. And it's better, it's good for everyone, right? Because if other folks, right, if you model that type of behavior, especially if you happen to be around trainees, people who are watching the way that you practice medicine, watching the way that you talk about people, they copy you, right? Residents, for example, they copy what it is they see you do. When they use language that kind of makes us cringy, and they say things like, oh, this patient is just coming in with total body dolor, and you don't check them on that, and they heard that from somebody. They think it's okay to say to you because it was okay to say in front of, you know, X, Y, and Z in maybe a different part of the hospital or a different part of the system. You know, they've seen that behavior before. So number one is, you know, I can't overstate, you know, the importance of really being in community with the folks that you're taking care of, and recognizing and putting front and center their humanity. And it's, you know, everything will fall into place after that.
Okay, so it's almost 7:30, and so really I wanted to have everybody give their last thoughts.
Oh, Bianca wanted to say something. Bianca?
Oh no, it's okay.
No, go ahead. I want you to say the things, but you can be the first one to start our kind of our wrap up. So you'll be the first.
So to kind of wrap up what everyone else was talking about is just being that person that can really just break it down and be real with them. They've heard all the medical terminology. They've had other providers. They want someone real and to make that connection. Like everyone said here, is to really just put them as a person first and not just a mark on your chart, not asking, oh, when was the last time you got tested, trying to check all these boxes and really just making that connection so that they feel like they can't open up to you, because most of the time they're going to be standoffish and not really tell you when the last time they had sex, or that they didn't use a condom because they feel that you're going to judge them and tell them that they have to get tested and then just beat them into using condoms. And just being that person that can really just make that connection and make them feel like they're human and they're just talking to someone that actually cares about them, really goes a long way to them opening up and being honest about their health. So, yeah.
Anyone else can go next.
I'd just like to say, breaking down racism in healthcare is a process, and it's going to be a long one. That being said, it's something that needs to be done, and it needs to be thought put behind it. And just think of it as, because if you start thinking about the big picture, sometimes it can become overwhelming. Just one person, one patient at a time. Mm-hmm. Do what you can do on that particular day with that particular patient. Start there, and then just keep challenging yourself little by little to build on that. But it can be broken down. It needs to be broken down. We need to do the work in order to work on racism in healthcare.
I'll go. I think just to summarize my thoughts on trust and trust building. Trust is something that our patients are giving us, right? Whether it coexists with mistrust and distrust, that we are already starting with a person that has decided to make themselves vulnerable by coming to see us. That's number one. If there is skepticism around treatments, around vaccination, if there is skepticism and hesitancy, it's very well placed and it's very well deserved. And we can't, and I cannot overstate that, because the goal of this talk wasn't to list off all of the ways that science, that medicine, that the institution of medicine, of healthcare in general, has violated the trust of entire communities, violated the trust of individuals over and over and over again. And when that is your history and you've proven yourself to be untrustworthy, don't turn around and make a person feel as though they are deficient because they don't trust you, when you've done nothing to start to repair the harm that has been done. So it's important to understand that, especially as we continue in this COVID-19 pandemic. It was important for us to do this 20, 30, 40, 50, 60, 70 years ago. I'm glad this conversation is happening. I'm glad that it's happening more than I've seen it happen before. But we can all acknowledge that it's happening too late. But I'm glad that it is happening anyway. There is a lot of work that needs to be done to dismantle white supremacy within many institutions, including the institution of healthcare. And if we are serious about wanting to close that huge gap and that disparity that exists in health outcomes when it comes to folks that have historically been marginalized in this country because of something that's socially assigned, then if we really want to get to the bottom of that, then we have to start being honest. We have to start telling the truth, and start to undo all of the harm that it really did take generations to have baked into the system to begin with. I'm excited to do the work. There's a lot of people that work in this system that's super excited to do this work, right? It's not just, part of it is, I'm jaded, but another part of it is like, I know, right? I see, and not just at the level of what I can do in my office, but, we need to start talking about policies, changing practices, to make sure that we are not continuing to add fuel to the inequity fire that's been burning in this country since its inception.
Well said. I don't know if I can, that's a tough one to follow. I think we are at a crossroads in terms of kind of what's been said. Obviously, again, 100 years ago, 200 years ago, you could have had these discussions. We are having them today. Where we go from here, I think we'll see, right? Because let's not forget that the minute we had President Obama in office, we were in a post-racial world. And so it'll be interesting, I think, to see where we go. I do think as a provider, it is your duty, it is your obligation to really emphasize trust. And that starts with a lot of things. Empathy is one of them. And if your patient is not trusting of the healthcare system or of providers in general, as opposed to being judgmental, be curious and just ask in a non-judgmental way where that experience stems from. What's the root of that? And I think if you actually allow curiosity to take place and you really explore that in a non-judgmental way, you'll get to actually understand where that patient comes from, and that will make your world richer, right? Just as when you dehumanize someone, you lose your humanity in the process, the opposite. When you give someone kind of a bit of their humanity, your world is also richer for that. And I think that's what we're missing as a society, and healthcare is a reflection of that. We are in a for-profit society, profit over lives. That's kind of how we got to where we got to now. You see it in COVID, you saw it in slavery, and everything in between. And I think, so at the individual level, that's where it starts. And I think you also have to advocate for policy change, just as was said. You have to have it, because you're swimming upstream. If your healthcare system only gives you 15 minutes, because that's where the bucks are, you're swimming upstream. And so I think you have to also fight to change that. That's, in order to be a healthy society, that has to change. We really have to actually place an emphasis on lives, on value, rather than on profit. And unfortunately, that's where we are now. COVID has laid everything bare. And let's see that this is hopefully an opportunity to actually change that narrative and rebuild in a better way.
So, I mean, I don't really have much to say after all that fabulousness, but, really, I guess what I would say is just, for people that are watching that, to choose allyship, right? Like Sabrina was saying, we have, empathy is something that we put on every day, that we have to put on like a coat, right? A lot of people don't understand, you're not walking in somebody else's shoes or doing all that stuff, but, it is still a choice as professionals, medical professionals and caregivers that we have to make every day we walk in the office. And it is the job of people that choose to walk alongside us or choose to serve people that look like us to understand, not to be competent, but proficient at working in this population. They have to be in it. They have to be embedded in it, like Sabrina was saying, and they also have to stand up for people that are being misused by the system. That is what I'm asking. I'm asking for, we've had generations of medical providers that have done so, civil rights movement, right? We had doctors going down south to make sure that, people could get care when they were beat up by, people from the Klan or police or, protesting or whatever. So all these things are things that we know how to do as medical professionals and caregivers. I think the thing is, though, is what I'm asking for allies to do, or whatever you want to call them, is that you have to understand that, your patient is within a system that is designed to not work for them. And the more that you understand that, because we understand it at a level we can roll our eyes at, but when you understand what it's like to be in that system and having to work within it and trying to benefit from that, that is where the sorrow comes from, being a patient within this system. That is the sorrow of people, Black and brown, that have had to carry that, and had generations that they've had to carry that after them or before them. So that is what I want them to walk away understanding, that this is a burning building. It's been burning for many years. It is your job to put it out. It is your job to examine it, get the people out, and put out the fire. So, and remember, from those that benefit from the system are the ones that actually have the keys, right? So I guess I'll leave that there. Thank you so much for everybody for this wonderful discussion tonight. I was so nice to really talk with all the fellow panelists here. Sabrina, Sire, Terri, Terri, and Bianca. And thanks to Mark for hosting this discussion for us. But this was fab. I hope we can get together and talk again. I would just love to connect with all of you offline anyway, which I'll do. So
Almost definitely.
email. All right. Thank you so much for attending. Thank you guys so much for listening, and we'll talk with you all soon.
Thank you so much.
Bye.